Today, I will demonstrate how to assess lumbar active range of motion. While measuring range of motion is important, the quality of movement often provides much more valuable information. Throughout each movement, we'll assess the QRSC complex, which is the quality of movement, range of motion, symptom reproduction, and compensatory movement patterns, which often indicate mobility deficits, weakness, pain avoidance, or motor control deficits. Within the lumbar spine, you have a lumbopelvic rhythm. So here, with this model here, going into flexion, you have the lumbar spine and the pelvis. Each of those components need to be moving properly in order to get the lumbar flexion. You have the lumbar spine that initiates the movement, and then you'll have the pelvis that anteriorly rotates over the femoral heads. We'll also be looking for the smoothness of motion, so no jerky movements or catching. We'll be looking for the segmental motion, so there's fluid motion within that spine and not just moving as one big segment. We'll look at symmetry, comparing movement patterns between the right and left sides. We'll look at balance and weight distributions. And then we'll be looking at the compensatory movements, which you can keep in mind the 4 M's, mobility deficits within muscle, joint, neural tissue, or fascial tissue, muscle power impairments or strength, motor control impairments or coordination, and muscle guarding for fear, avoidance, or pain to offload a certain segment. Today we are going to be going over lumbar range of motion. We will be assessing and looking at compensatory movements for the thoracic spine, lumbar spine, hips and pelvis, as well as the knees and feet. We'll be looking for lateral trunk shift, weight distribution, rotation of the trunk, and if there's a Gower sign when coming back to standing position. All of these will give us information to advance our examination. I'll have the patient step up here. Again, to standardize each test, I'll place my foot between their feet, have them touch my feet, and remove your foot. So each test, they're starting in the same position and can be reproduced. I'll have them lift their shirt so we can see what the lumbar spine is doing. Okay, I'll have you go ahead and bend forward as far as you can. Perfect. So here we are again looking at the thoracic spine, how much flexion is involved here if they're compensating for the lack of mobility in their lumbar, which he is not. Then we're going to look at the lumbar spine here. You should have a nice reversal curvature of that lumbar lordosis, which he does. And if it was more of a flat back, it's going to be due to lack of mobility in the lumbar region. And then we're going to look at the hips. Are they anteriorly rotating over those femoral heads? Are they posteriorly rotating because of tightness in the glute muscles or hamstrings? Then we're going to look at, are they internally or externally rotated with those hips? Are the knees bent excessively due to hamstring tightness or balance deficits? Are their feet internally or externally rotated for balance again or mobility restrictions? Then we're going to look, are their trunk rotated to a certain way to offload for pain? Are they having trunk shift to again offload for pain or fear avoidance patterns? And then when they return back up to standing, we're going to look for that Gower sign. Do they have to crawl up their legs due to strength deficits or again pain? Next, we're going to have you put your hands on your hips, and I'm going to have you bend back as far as you can. Good. And again, kind of bracing the patient here. So we're going to kind of go down that chain again. What are we looking for? We're looking for those 4 M's, mobility, muscle guarding, and motor control. Okay, go ahead and go back again. So we want to see what the lumbar is doing here. We want to see, is the hips excessively posteriorly or anteriorly flexed? Are the knees excessively flexed? And then knowing the force couples with the anterior and posterior pelvic rotations. That is a huge contributor to know what is tight, what is weak here. Then I'm gonna have you face this way, okay? Hands at your side. Then you're gonna just slide down your leg. Perfect, okay. So go ahead, slide back down. Have the patient there. Again, we're looking here. Are they laterally shifting their hips to the side to offset for pain? Are they tight in the quadratus lumborum here? Are they bending their knees? Are they rotating their trunk to get excessive motion due to lack of the lumbar mobility? And then you'll have them reassess the other side and then you really want to compare left to right here. Okay, then last one, I want you to cross your arms. I'm gonna brace down here at their pelvis, and I want you to rotate over your shoulder. Good. Rotate the other way. Good. Okay. So then again, with the rotation, comparing right to left for that symmetry. Now I'm gonna have you turn around and face this way. So now we're gonna do measurements with the double inclinometers, which has the most inter and intra reliability ratings. So the first one, we're gonna palpate or find the bottom of the rib cage here, which is that 12th rib. Kind of make a C formation, follow it connected to approximately that T12. You're gonna place one inclinometer there. Then I'm gonna go down here, find that iliac crest or that hip bone, making a C formation, should connect you to the PSIS or that bony protrudence in the back. And then right in between those two PSISs, we're gonna place the other inclinometer. Now we want to zero both of these out. Okay. All right, now same thing, I'm gonna have the patient flex forward as far as they can. Perfect, and we got 160, so the difference of those would be 40. Go ahead and come back up. And normal lumbar flexion is between 40 and 60 degrees. Those would be the same landmarks for extension. And then when you do side bending, you would have them more in a frontal plane position like this. And same protocol, zero them out, take the difference, and that would equal your range of motion. So to follow up, we want to look for the quality of movement rather than just the quantitative number. You want to look for the QRSC, quality of movement, range of motion, symptom reproduction. So you want to be checking in with each motion if there is pain and where the location of pain is at. Then you also want to be looking for those compensatory movements, seeing what could be tight, what could be weak, what could be balance deficits, what could be coordination deficits, or are they altering their movements based on pain or fear avoidance patterns. Range of motion tells us how much they can move, but the quality of movement tells us why they are moving in that movement pattern.